So I'll start the talk by highlighting the agenda for the talk today. I'm going to go through the population and statistics, talking about aging and sleep history, which is a bigger challenge for all the clinicians here in their OPTs with their busy schedules. Going through each patient's sleep history can be a mammoth task. Then I'll be browsing through normal sleep, challenges in sleep as we age, insomnia, and other challenges that we face. As we know that the speed of population in India is at a rat race. Now this rat race against populations that are growing across the globe warrant that India reaches a 25% of the population is going to be over 65 years of age by 2050. Japan, on the other hand, has actually already crossed these statistics way back in 2012. And as the populations are getting older, so is the burden of sleep issues increasing. This is how we're going to look like and feel like if we don't do anything about it today. Memory loss, confusion, solving problems will be a difficulty. Trouble with familiar names, tasks is going to be a hassle tomorrow, so we better take care today. Coming to the overview of sleep, sleep is actually on the basis of physiological and electroencephalographic parameters divided in non-REM, which is non-rapid eye movement sleep, and rapid eye movement sleep. The non-REM sleep is in stages 1, 2, and 3. Earlier, we had a classification of non-REM 4, which has now been taken out of the latest guidelines and classification. The muscle tone, EOG, EMG, and EEG are a part of the polysomnography studies when we do a sleep study at night. And highlighted here are the parameters and how they change with sleep and age. The National Sleep Foundation recommends that an elderly person sleep for about 7 to 8 hours per night. With our busy schedules and erratic clouding in our brains, we know how much we have work to cope up with and challenges to deal with, which compromise on this basic need of all humans. Running through a hypnogram in the young, followed by the elderly, the first two hypnograms elicit sleep latency in the younger adults. So in the younger adults, there is more consolidated sleep. The sleep onset time is minimal. We see consolidated REM sleep. Each sleep cycle is a cycle of 90 minutes, which is periodic and phasic. As compared to the second graph, the second hypnogram that we see, where sleep is fragmented, time wake after sleep onset is much more. Total sleep time is decreased, number of arousals are higher, and slow wave sleep is decreased. Now, these are the factors that influence our sleep day in and day out. Multiple comorbidities, lifestyle issues, dincharya or routine issues, our dietary habits, everything contributes to a good night's sleep. Going through the aging process, the reasons for the increase of sleep disorders in the elderly are not only physiological, pathological, but may also be related to the drugs that one may be consuming as one ages with comorbidities. The peripheral sensory systems that are going down, altered tissue morphology, mental states, and central sensitizations all contribute to this. Factors that influence sleep in the elderly patients, again, as I mentioned, medical illnesses, psychiatric illnesses, environmental changes are a major contributory factor. Sleep problems that arise with age are significantly higher in people with pre-existing medical comorbidities, as shown in this current graphic. Anxiety and depression, arthritis, chronic pain, neurodegenerative diseases, diminishing senses, endocrine metabolic disorders, cardiovascular disorders, balance, gait, and movement restriction, anemias are all very important contributory factors to our night sleep. In the earlier classification, common sleep complaints were classified as primary or secondary. The newer classification, however, classifies them in a different way with these 4 primary heads that we see on the board. Insomnia contributing to a vast 30 to 50% of people having difficulty in sleep initiation and sleep maintenance with multiple nocturnal awakenings, obstructive sleep apneas, which are breathing interruptions during sleep, circadian rhythm disorders, restless leg syndromes to be the most common ones. The secondary causes include the socio-emotional factors, mobility, balance and gait, lifestyle changes, polypharmacy, and in this graph, we see the difference in the gender of slow wave sleep as one ages. We see that there is a significant decrease in the male slow wave sleep with age. The prefrontal cortex and the hippocampus, as they degenerate with age, show corroborative changes, which is elicited on the right side in the colorful diagram, on how slow wave sleep, which is the hallmark of stage 3 sleep, and the spindle activity, which is a hallmark of stage 2 sleep, decrease with age. The impact of poor sleep cannot be questioned, as multiple studies now are coming to highlight not only muscle strength, Alzheimer's, frailty, sarcopenia, and many systemic disorders to be a much contributory factor towards the sleeping conditions of the elderly and the young today. The important lifestyle and socio-emotional psychological factors that contribute towards sleep also contribute towards poor cognitive performance and function are muscle repair, perceived exertion, immune function goes down, muscle glycogen repletion is decreased, altered endocrine function, increased exercise-related injuries, increase in pain sensitivity, increased chronic health issues are all because of poor sleep. The global statistics and perspectives on sleep in the elderly. The global burden of sleep disturbance is about 30 to 50% across the globe. However, the urban Indian population of seniors reports about 25 to 40% disturbance. We are not far away from the global numbers if we don't take care now. Seniors affected by insomnia globally are 30 to 40%, whereas Indians report a 17 to 30% influence of insomnia. This number may be skewed, these percentages may be skewed because of lower reporting. Increase in rates of obesity and metabolic disorders contribute to a high 20 to 30% of obstructive sleep apnea, whereas in India, 30 to 28% of the elderly population contributes to this burden. Elderly with restless leg syndrome account for 15%, which is slightly lower due to genetic and environmental and dietary factors in India. The highest contributory factor or sleep challenge in the elderly today is insomnia. The DSM-5 diagnostic criteria highlights dissatisfaction with quality or quantity of sleep for at least 3 nights in a week for at least 3 months associated with 1 or 2 of the following to be a diagnostic criteria for insomnia. causes clinically significant distress or impairment in routine functioning, occurs even when there is enough time to sleep, does not occur exclusively during narcolepsy, breathing-related sleeping disorders, circadian rhythm disorders, or any other coexisting sleep disorders, does not occur exclusively during the course of another mental disorder, not due to the direct physiological effects of a substance. Now, these criteria, there is difficulty falling asleep, staying asleep, or early morning awakenings, which further classify insomnia. Again, this is the same slide. This further classifies insomnia as sleep maintenance or sleep initiation in insomnia. The causes of insomnia may be medical or psychiatric, iatrogenic, or psychosocial. Anxiety disorders, asthma, CHF, COPD, dementia, something as simple as reflux is a major contributory factor to decreased sleep. Iatrogenic factors include medication, alcohol, steroids, sympathomimetics, caffeine, our teas and coffees that we love are all iatrogenic factors that hamper our sleep. Psychosocial, bereavement of a dear one, financial stress, travel, marital difficulties, poor sleep hygiene, children bothering us, or parents being a burden that we so-called think is absolutely a misnomer and cause us stress, which contribute to the insomnia that we have. For screening, the most important is the patient history. A patient health questionnaire is a mandate for all clinicians to follow, even if it takes a long time in the OPDs. The geriatric depression scale, the general anxiety disorder questionnaire, the PSQI, ISI, the sleep diary are all mandatory screening tools. However, we also have optional tools like actigraphy and the ring, which is a latest invention of modern day, wherein just slipping a ring in your ring finger will help you diagnose something so easily. A sleep diary is what we all abide by, the sleep physicians. This typically highlights, this is a subjective understanding of the patient's sleep, where the patient is supposed to put in work, schedule, M for medication, C for caffeine, A for alcohol. The first row on top highlights an E, which is an exercise, A, which is an alcohol. The darker highlighted portions are when a person takes a nap or sleeps, goes to bed. The I or the bar at 10 p.m. is actually when you hit the bed. At 11 p.m., this individual is still unable to fall asleep and is tossing and turning in bed, which may be the case for a lot of us here. And in the morning, at 7 a.m., when this person wakes up, after a brief hour, which may be a very hard hour at night, while tossing and turning because this person cannot get back to sleep, he has a shot of caffeine with his medication. Now, this 2 weeks synopsis of a person's sleep schedule helps us understand the subjective emotions and the subjective pattern of the person who's sleeping. The instructions that we give to a patient while filling this is that this is not supposed to be filled in the middle of the night when you're actually looking at the clock and unable to sleep. It is ideal to wake up in the morning and do a retrospective filling of this. Diagnosis of insomnia highlights at least one symptom that I've previously mentioned to be occurring at least 3 times in a week for a period of 3 months and daytime impairment. Funneling down, insomnia diagnosis is only about 6% in the OPDs, shows a latest research study. The first-line treatment for insomnia and sleep disorders is clearly non-pharmacological, as highlighted by the American Academy of Sleep Medicine Clinical Practice Guidelines. Cognitive behavior therapy, or CBTI, forms the mainstay of insomnia. The other non-pharmacological therapies for insomnia include stimulus control, sleep restriction, paradoxical intention, relaxation techniques, cognitive behavior therapy, multi-component therapy, temporal control therapy, details of which I'm happy to share, but I'll be skipping through these as we are running behind time. Again, for choosing the ideal pharmacological treatment, this chart highlights the pathways for choosing the right treatment for an individual based on the kind of insomnia a person may be having, which is sleep maintenance insomnia or sleep onset insomnia. We have drugs like Ramiltion, Suvorexant, the Z-class category drugs, amongst others. Use of sleep medication amongst the elderly from 65 to 80 is shooting at a peak of 31%. Obstructive sleep apnea. We all know the etiopathogenesis of obstructive sleep apnea, which ultimately leads to inflammation, oxidative stress, disturbed circadian rhythms, and endothelial dysfunction, causing irregularities in sleep at night. Hypoxemia or reoxygenation, the autonomic dysfunction, the arousal sleep disruption, intrathoracic pressure changes, and hypercapnia contribute to the pathophysiology that lead to the disease mechanisms. Inflammation, atherosclerosis, endothelial dysfunction, etc., contribute to the associated CVDs. The long-term consequences of obstructive sleep apnea are metabolic disorders, mortality with high mortality and morbidity, cardiovascular consequences, and neurocognitive dysfunction. Again, I will not get into the details looking at the paucity of time. Skipping through this as well. The trait-based precision medicine is the latest concept in the treatment of obstructive sleep apnea, where we establish the role of traits in pathogenesis of obstructive sleep apnea, initiate therapy with gold standard measures, use the traits to predict response to current treatments, followed by clinical surrogates, apply the surrogates in multimodal therapies, point of care validating traits with measurements, and target obstructive sleep apnea trait to initiate therapy for each individual. And these studies are currently being done by the Harvard Group in Boston. Again, the challenging aspects of sleep in the elderly are contributed by lifestyle, polypharmacy, CPAP, compliance, which is a big issue. Surgical options are there, but harder and more difficult. Alternative devices, again, difficult to maneuver and initiate by the elderly alone. Nerve stimulation, drug therapy, and oxygen supplementation also add to multimodal therapies. Modifiable risk factors, diagnostic polysomnography, change in systolic blood pressure, excessive daytime sleepiness, causing sleep fragmentation and arousals at night, and oxygen desaturation all contribute towards cognitive decline that are directly tangible, and we are able to elicit this in verbal, visual, long and short-term memories, executive functioning, and motor functioning. The chart to the left actually highlights sleep disordered breathing before and after CPAP therapy and the changes that we're able to see. Future directions for physicians may be systematic studies that may be needed in a stepwise approach to help the elderly function better, have a great scope for learning in the OPDs. Circadian rhythm, diet, psychology, and gut microbiome are also related to the sleep-wake rhythm that contribute to the sleep-related disorders in the elderly, which are not limited to neurological diseases, endocrine diseases, adding to the mental health burden of what they already have. Again, health outcomes and correlates with diabetes, type 2 diabetes. Recommendations for the Indian healthcare providers. Assessment of medication and assessment of the patient are of utmost importance. Assessing drug-to-drug interactions, identifying non-beneficial therapy and simplifying therapy, identifying high-risk therapy and reconsidering whether it is actually needed or not, identifying goals for care and adjustment of medication that are consistent with the needs of the patient, identifying functional status deficits and readdressing medication, eliminating and clearing toxicity in patient systems, and adhering to the barriers that come in place of a compliant patient are something we all need to see. Integrating sleep health in the OPDs from a general practitioner to a super specialist is the need of today. Highlighting in the next few slides the relationship between pain and sleep problems, feed-forward and feedback mechanisms contributing to sleep disturbance and pain. Likewise for polypharmacy, as I've previously mentioned. The highest risk being of beta blockers, antidepressants, and diuretics. Hormones like melatonin, which are secreted and cause dysregulation of the sleep-wake cycles. Nocturia, polypharmacy, movement disorders, dementia, reflux disease, pain, heart failures, depression, and respiratory disease all cause impaired sleep. Sleep is not a unidirectional or a unimodal entity, and it needs to be catered by each one of us in our clinics. Identifying medication risk and deprescribing should be the goal. Socio-emotional challenges that affect the elderly in complying to the treatments may be not limited to loneliness, loss of loved ones, social anxiety, retirement, and loss of purpose, fear of falls, nighttime anxiety, chronic stress, for which we need to reinforce positive relationships and support. The importance of dincharya that has been emphasized by our elderly at each one of our homes comes into play here. Alternative medicine has not fallen shy from supporting mainstream to support each one of us sleep in peace. Alas, we do not consider them important. Holistic sleep solutions are important and backed by evidence. Ashwagandha, Brahmi, Shankhapushpi play an important role in sleep disorders and have enough evidence that we can support patients with adjunctive therapies. To summarize, insomnia disorders and chronic insomnia disorders, treatment of choice being cognitive behavior therapy. Sleep-related breathing disorders, the treatment of choice is PAP therapy. Circadian rhythm disorders, light and rescheduling. Sleep-related movement disorders with dopamine agonists and alpha-2 delta ligands. Parasomnias need reinforcement of sleep hygiene. Central disorders of hypersomnolence need wake-promoting medications and, again, sleep hygiene to be in place. I can't emphasize less on the importance of sleep routine and sleep hygiene. Thank you.
Thank you very much for an excellent talk. And basically, good sleep is an indicator of good health, both physical and mental. So we need to aspire to have good sleep, and you have given the guidelines for abnormality in sleep, diseases affecting the sleep, and how we can overcome and have good sleep. Thank you very much.
Thank you, sir, for having me. Thank you to the audience for being a very patient one.